So I just wanted to go over some of our approaches to adjuvant therapy, and specifically adjuvant systemic therapy. And I wanted to start out with what are our goals in adjuvant treatment specifically? What are we trying to do? And our primary goal, of course, or I should say our first goal, is to try to decrease the risk of relapse in our melanoma patients. And as you can imagine, the likelihood, the chance of not relapsing is higher in earlier stage patients. So for example, stage 3A, as opposed to our stage 3C patients who do unfortunately have a decreased chance of not relapsing at the 5-year mark. So in addition to trying to prevent relapses of melanoma, ultimately we'd like to improve overall survival. So not just your time without having your melanoma recur, but how long you live overall. And trying to do all of this, of course, without causing increased toxicity in patients. Okay. Can everyone hear me? That's better. Okay. Okay. So the way I generally approach when we have patients come to clinic and we're going to have a discussion about adjuvant systemic therapies is I actually like to go through briefly the NCCN Guidelines. So NCCN is National Comprehensive Cancer Network, so it's a group of about 25 cancer centers in the country, so Moffitt's a member. And I think they do a nice job of breaking down, and the mouse works too, breaking down some of the options. So again, Dr. Sondak talked about, of course, the primary treatment, sentinel lymph node biopsies, complete lymph node dissections, and our focus here is what to do afterwards. So the 4 options that I wanted to discuss is observation, interferon briefly, which has been around a long time, ipilimumab or Yervoy, which was just recently FDA approved late October, and finally clinical trials. So I'll just go over these in this order. And primarily I'll focus on stage 3 melanoma patients just because this is the stage where several of the drugs have FDA approval and where a lot of the focus has been for clinical trials as well. Okay, so in terms of observation, so generally when our patients come to clinic, we'll talk about, here's the approved treatment options in the adjuvant setting, here's some clinical trials, and there are patients who do select for observation ultimately after hearing about what's available. So we then talk about what exactly is observation, what does surveillance of melanoma after you've had your lymph node dissection, your complete surgery, you have no evidence of disease, and now we want to watch you to make sure you don't recur. How do you do that? And part of that is, of course, again, these are looking at the guidelines, history, and physical exams. Specifically focusing on, of course, lymph nodes and skin exams, which are always done best by dermatology colleagues, as you heard from Dr. Patel earlier, and imaging as well. In terms of the frequency of physical exams and imaging, there's not necessarily a right way and a wrong way, as in you have to do it this way and this is not correct. The guidelines are in the first 2 to 3 years, every 3 to 6 months in terms of physical exams, and then going out to annual visits after the first 3 to 5 years, because as you can imagine, the risk of relapse does decrease as you go out beyond the first 3 to 5 years from your surgery for your melanoma. In terms of imaging, it's always, CT scan, PET scan, MRI, chest X-ray. Again, no clear, right or wrong answer. Part of that is, physician's practice, patient's preferences, but again, 6 to 12 months, and again, less frequent as you go out further from your initial diagnosis. And of course, as clinically indicated, again, if you come in with, of course, any concerns, symptoms we're worried about, and imaging then as well. Okay. So briefly to talk about high-dose interferon, which is, I think it was initially approved for melanoma back in the 1990s. This has been around a long time and probably familiar to patients with stage 3 melanoma who come to talk to an oncologist. So the way it works, basically, it's presumed to be an immunomodulatory agent and ultimately supposed to lead to death of melanoma cells. The most commonly used regimen, it's not the most convenient dosing method. It does involve intravenous injections 5 days a week for 4 weeks, so about a month of, treatments, followed by under the skin subcutaneous injections of the interferon 3 times a week for up to a year. So that's the commonly used high-dose interferon regimen. So in terms of, I won't go into all the trial results with interferon. There's been dozens of trials looking at this since the 1990s. But in terms of what they've shown in our stage 3 melanoma patients is shown a benefit in relapse-free survival compared to placebo observation. So basically, if you did receive interferon, your survival without having a relapse was longer than if you didn't receive interferon. But in some of the large trials where they've done follow-up of these patients over a decade, they have not found an overall survival benefit. So just because you lived longer without your melanoma recurring didn't necessarily translate into you lived longer overall. They have also looked at, in different trials, different dosing regimens of interferon. So of course, toxicity is a big concern. So they've said, well, can we do lower doses? Can we do maybe 1 month instead of 1 year? But unfortunately, doses have generally been shown to be subpar compared to the regular high-dose interferon. So again, just to sum up, so this is from one major study, does improve relapse-free survival, but not overall survival. There have also been attempts to do meta-analyses, because there are so many interferon trials. Why don't we take results from 12, 15 trials and data from thousands of patients and put all that together and see if we can detect a difference that way. And again, benefit in relapse-free survival has been seen. So in this large meta-analysis, a 17% improvement in relapse-free survival. And this meta-analysis did actually show, putting together data, I think from about 12 clinical trials, about a 10% benefit in overall survival as well. But then there are other meta-analyses that don't show the overall survival benefit. So unfortunately, it's tough to say with absolute certainty. There's some suggestion of overall survival benefit, but we're not able to say it with absolute conviction. Pegylated interferon, just to briefly discuss, or Xylitron, this has been, I think, FDA approved in 2011. So it's a different formulation of interferon, a little bit more friendly in terms of the dosing, doesn't have the IV portion, the 1-month IV treatments that high-dose interferon has. It's just subcutaneous or under the skin injections. And instead of 3 times a week, it's once a week, but up to 5 years with PEG interferon. So to say though, in the large clinical trial that led to its approval, I think it was the median length of treatment was though only about a year. So large majority of patients didn't actually get 5 years with this drug. In terms of what the results showed with this study, again, seeing a benefit with relapse-free survival. So that's these curves on the left here, but not seeing a benefit in overall survival. Again, these lines basically observation versus the PEG interferon overlapping, so there's no difference there. But based on the benefit in relapse-free survival in stage 3 melanoma patients following complete lymph node dissection, it was FDA approved and remains an option. There are some ongoing analyses, with both PEG interferon and high-dose interferon to see can we find subgroups of patients that are maybe more likely to have a benefit with these drugs versus less likely. And there's been some analyses suggesting that maybe patients with ulcerated primary melanomas, which Dr. Messina was discussing in her talk, ulcerated lesions might actually have as more of a benefit with interferon compared to non-ulcerated primary. But of course, that needs to be looked at in a clinical trial setting, there's an ongoing study looking at actually stage 2 patients with ulcerated primary melanoma. So stage 2 patients are ones without any lymph node involvement. So we'll have some more information about that, hopefully in the next couple of years. Okay, and toxicities I won't go into, but I think, again, many people who read about interferon will be familiar. This is the FDA black box warning for interferon with psychiatric disorders, autoimmune, ischemic, infectious. So it's quite a list of toxicities. Okay, so moving to some newer treatment options, I briefly wanted to discuss ipilimumab or Yervoy, which is an immunotherapy drug that was initially approved for the unresectable stage 3 and for our metastatic melanoma patients back in 2011. And ipilimumab falls into the class of immunotherapy drugs. And I won't go into too much detail about the exact mechanism of the drug. It's basically an antibody, and the basic concept is that it allows your body's immune system to recognize and attack melanoma cells in a more efficient manner. So you'll hear definitely more about ipilimumab in the metastatic talk by Dr. Kushalani in the afternoon, and some of the side effects from this drug as well. But because it was recently approved in stage 3 patients, we'll discuss it briefly here as well. One interesting thing with ipilimumab as the newest FDA-approved drug in the adjuvant setting is it does have a category 2B recommendation in the NCCN Guidelines. And that 2B is usually reserved for drugs where there was, among the panel members, a lot of debate and discussion in how strongly to recommend it. And I briefly wanted to go over why that might be. So this was the clinical trial that led to the FDA approval of ipilimumab in the stage 3 adjuvant setting. And this was just published now about a year ago. A very large phase 3 trial, almost 1,000 patients, where patients were randomized to either placebo or ipilimumab, but interestingly at a 10 milligram per kilogram dosing, intravenous, every 3 weeks for 4 doses, and then once every 3 months in IV dosing for up to 3 years, which is different than the metastatic dosing of ipilimumab, which is 3 milligrams per kilogram and just 4 doses, and then you're finished. In terms of the published results that led to the FDA approval of this drug late last year, the investigators did find benefit, which is their primary goal with this trial, in recurrence-free survival. Median, again, 26 months compared to 17 months with placebo, so about a 25% benefit. And they had some data available out to 3 years for relapse-free survival rates, 46% versus 34%. But to keep in mind, we don't yet have data on overall survival benefits. So we know that sometimes with some of the interferon trials, you also saw recurrence-free survival benefit, didn't always translate to overall survival. With ipilimumab, we don't yet have the answer to the question. The patients on the trial need longer survival follow-up before we can see, is there a benefit in overall survival in the stage 3 patients who received this drug versus observation. A couple other questions that come up with ipilimumab. So, if you ever read the original trial, the publication for this trial, the authors also comment on it, is there a benefit in stage 3A patients? Because if you look here, not to get into the statistics much, but anything that touches this line here in the middle is not statistically significant. So it's a bit of a question for 3A patients in this trial. How strong was the benefit in recurrence-free survival for stage 3A versus the B and the C patients? The bigger question and concern, and probably what led to some discussion in the NCCN panel for this drug, was the toxicity that was seen. And you'll hear a little more about the immune-related toxicities you tend to get with immunotherapy drugs in the discussion for metastatic melanoma. But suffice it to say, with ipilimumab, and especially at the higher dose used in this trial, there was significant toxicity. So gastrointestinal, so again, this is grade 3-4 toxicities, which are more severe and in some cases leading to hospitalization, as opposed to the less severe grade 1-2 toxicities. So the side effects like GI-related, diarrhea, colitis, liver enzyme abnormalities, endocrine abnormalities, again, all unfortunately known side effects of immunotherapy. And I think what's of note is that over half the patients on this trial who received ipilimumab were not able to continue with the drug. And over a third actually could not get through the initial 4 doses. And there were also 5 treatment-related deaths. So not patients who died because of any kind of a relapse of their melanoma, but just from the drug itself, due to colitis, myocarditis, and multi-organ failure. So in terms of, with this trial, the question is, how does this fit in now with our systemic adjuvant options? So again, we don't know yet the effect on, is there a benefit in overall survival, but hopefully we'll find that out in the next couple of years. We also don't know how does ipilimumab compare to interferon. Again, this trial randomized patients to ipilimumab versus placebo, not to interferon. So luckily, there is a trial that I think we also had at Moffitt, and that completed accrual, that randomized patients to interferon or to ipilimumab, and also used the 3 milligram dosing as one arm in addition to the 10 milligram dosing. Because what I've heard sometimes oncologists may consider doing in practice is saying, well, we know there's some benefit with ipilimumab, but the 10 milligram dose can have a lot of side effects. Why don't we just give the 3 milligram dose? Because that's approved in the metastatic setting to our stage 3 patients. And I would caution against that because that's not what the trial looked at. So you don't know if you would actually get the same recurrence-free survival benefit with the 3 milligram dose of ipilimumab that was seen with the 10 milligram dose. So it's possible, you might, you just don't know the answer. It's potentially you may be using a subtherapeutic dose of ipilimumab if you did the 3 milligrams. So, but hopefully with this trial and others, we'll have an answer to the question of the lower dose of ipilimumab and whether there's a benefit in the adjuvant setting as well. So other clinical trials, so moving forward, you'll hear a lot more about anti-PD-1 antibodies and other immunotherapy agents, which are now FDA approved again in the metastatic setting, so drugs like pembrolizumab and nivolumab. Compared to ipilimumab, these drugs in the metastatic patients do lead to a higher percent of patients having significant tumor reduction and are also generally less toxic. So of course there's a lot of interest in looking at them in the adjuvant setting as well. So one trial that we have at Moffitt and then other sites is the Southwest Oncology Group trial, where stage 3A patients with 2 nodes, positive nodes, and B and C, will be randomized to the anti-PD-1 antibody pembrolizumab versus high-dose interferon. My understanding is because we now have FDA approval of ipilimumab, I believe the investigators are in the process of amending the trial to also allow ipilimumab as an option. So if you get randomized to the control arm, you may be able to pick between interferon versus ipilimumab, versus, again, the other randomization would be to the pembrolizumab. There have also been some other recently completed trials, which were also at Moffitt, looking at, again, in stage 3 patients and 4 patients in post-surgical setting, comparing nivolumab, an anti-PD-1 antibody currently approved in metastatic patients, to ipilimumab. So hopefully in the next couple of years we'll have results from that. Also another trial which had a cohort looking at ipilimumab and nivolumab in very high-risk patients, stage 3C, stage 4. And again, you'll hear more about this combination of 2 immunotherapy drugs, ipilimumab, nivolumab, more in the metastatic talk. And there's also a trial ongoing in Europe through the EORTC looking at pembrolizumab versus observation. So hopefully with some of these trials and the results, we'll have a much better idea of where immunotherapy fits in the adjuvant setting. Briefly wanted to touch on target. We're out of time? Okay. Just have a couple slides left. Targeted therapies, you'll hear much more about BRAF mutations and BRAF inhibitors in Dr. Smalley's talk later on. But specifically in the BRAF mutated patients, there's an interest in looking at BRAF and combined BRAF and MEK inhibitors in the adjuvant setting. So I think these trials are ongoing, and hopefully we'll have some results from those next couple of years. And finally, neoadjuvant therapy, I think you'll hear more about in the next few years. Much more common in some other cancer types, like breast cancer, where patients get chemotherapy prior to surgery. Also of interest in melanoma, doing upfront systemic treatment before surgery to see, can we do a less morbid surgery, or for patients who are borderline resectable, can we make them resectable by giving systemic treatment up front? And there are ongoing trials looking at that, and we've done this in the clinical, with discussion with our surgeons, with some of our patients as well. So again, moving forward, last slide, there's again a lot of new agents that are being looked at in the adjuvant setting, which is exciting to see, and ultimately identifying markers to help us determine which patients are at a higher risk of relapse. Hopefully you'll know more about this in the next few years, and moving towards personalized approaches, if we could predict, again, which patient would be more likely to respond to which systemic treatment, would be very helpful as well. And that's it.